Good afternoon, everyone. We're so delighted that you're able to join us today at the Cepheid-sponsored Integrated Symposium. My name is Devasena Jnana Shanmugam. I'm Vice President of Medical Affairs at Cepheid, and I'm joined by my co-chair.
So I'm Laurent Dortet from France, Paris, and a microbiologist in the National Reference Center for Antimicrobial Resistance. Nice to meet you. Nice to be there at this Integrated Symposium.
And our symposium will be about expert insights on diagnostics and antimicrobial resistance. We're so happy that we're being represented by many speakers, and they will have a global representation telling us about the importance of diagnostics and the important role that diagnostics plays in combating AMR. And we'll also learn some insights about near-patient testing and how that can be applicable in certain very specific settings. So with that, I'm going to go ahead and introduce our first speaker, is Professor Alison Holmes. Professor Alison Holmes is a professor of infectious diseases at Imperial College. She is also the director of the Fleming initiative that Cepheid is a partner in. And she will be talking to us about protecting patient pathways and healthcare delivery through the intelligent use of diagnostics. Professor Holmes, I leave it to you.
Thank you so much, and how wonderful to see you all today. Really fantastic. So those are my disclosures, and as Devasena says, this is what I'm going to talk about, which is the intelligent use of diagnostics to protect patient pathways, but also to protect healthcare and its delivery. So just a tiny little bit about the Fleming Initiative, which is a recent initiative, which is really exciting, which is bringing together research scientists, policymakers, clinicians, behavioral experts, the public and commercial partners, as outlined, to provide networks, expertise, and skills to provide equitable solutions to AMR, but at a global scale. So I'm wanting to argue that can we all think differently about diagnostics? I've worked for many, many years in the National Health Service and some other health services too, and I really, really want to present the argument that diagnostics are not only for therapeutic decision-making, and that we need to get this message out loud and clear, but they're also critical for protecting patient pathways. They're critical for the delivery of safe healthcare, the generation of data, which is increasingly important with AI and machine learning, and also the optimizing of management and our prevention of infections. But they also can be used to address issues of representation of populations, monitoring, informing decision-making, and providing the platform for real-world research. And I think we should be considering these across the whole healthcare system and actually beyond healthcare, because we should think about it in a kind of one health and planetary aspect, and also decentralized approaches. Okay, so moving on, patient pathways. So what do we mean by that? Well, actually, this is a really easy peasy one. This is in acute healthcare, but we all know it's not quite as easy as that, much more complex, and everybody comes back in again, but we don't want them to. So let's think about the factors that drive infections, seasonal increases in infections that we see, really boring, happens all the time, and yet somehow we can't deal with them. Quite extraordinary. Turnaround time around diagnostics and how our laboratories perform, vaccine coverage in our communities, the infection control strengths, investment, and also the HCI infections and outbreaks. So what's the impact of all of this? Major headaches, really difficult, hard to deal with. Awful if you're trying to manage systems, awful if you're a patient, awful if you're a relative. Delayed diagnosis and management, healthcare illness in staff that we don't think about enough, and also absence from staff indirectly because they're caring for family, morbidity of the nosocomial infection, increases in healthcare utilization, closures, bed occupancy and delayed discharge. But something we really have to consider is how all of this drives the consumption of antimicrobials and drives antimicrobial resistance. So, okay, this is pretty old data across Europe, but it looks at how much antibiotics prescribed in European hospitals from the point prevalence work done then was around prescribing for infection acquired in hospital. An awful lot, 1 in 5, not too brilliant, we could all do better. That is pretty shocking. And diagnostics could really help us with this. Okay, that was old data, but this is data from the UK from November last year. 1 in 5 antibiotics prescribed within our healthcare is for healthcare-associated infections, and diagnostics could help us do a lot better with that. But I also want us to think about this this duality of both healthcare as a driver, but also healthcare as a casualty of antimicrobial resistance, because we cannot deliver safe healthcare with all of this increasing, expanding, amplifying. So we have a major role for diagnostics in minimizing the driving force of preventable infections and the pressure of massive antimicrobial use in our healthcare. And in turn, this protects our patients, our vulnerable patients across pathways, as well as the delivery of that healthcare. You've all seen this a million times, I bet. This is the Chris Murray burden of AMR. Really, I'm clutching at straws here, but how fantastic in the neonatal range that there's been a shrinkage of the burden, and a lot of that to do with prevention, nothing to do with new antimicrobials. But what's really interesting is this really increasing burden in the aging population. And this is going to be a huge issue for us to deal with. And I think we need to think about how diagnostics can really help in terms of minimizing this burden across all of healthcare, community and acute healthcare. So just thinking about how does this really impact how our hospitals work. So this is from my lovely colleague, John Otter, a tiny study, but really looks at the impact of CPE within our hospital, in a public sector hospital, in the NHS, but a pretty, 40 patients. Look at the impact that had in terms of the economic impact. But it's not just the impact in terms of what's happening within acute healthcare. We also need to think about what happens in the community in terms of antimicrobial resistance. And also, not just the impact in the community, but how that impact in the community then has an impact within our acute healthcare. So this is the work by another brilliant colleague, Nina Zhu, who looked at what was the burden of CPE and what does that mean in terms of when people get admitted to hospital. And this is just looking within UTIs. It's pretty shocking, pretty amazing, and more work needs to be done around here, and diagnostics could really facilitate this. So a little bit about the lessons from COVID. This so highlighted the need to protect our non-COVID patients from acquiring infection. Shockingly, 20% in the UK of the COVID infections were acquired in hospital from patients in for other reasons. And we need diagnostics to help us capture and address the direct and indirect impact of infections. And generate that data that they generate is critical for us to think more clearly about how strategies impact on our healthcare and patient care. And again, not just related to COVID, it actually worsened our performance in terms of bloodstream infections and the mortality and morbidity associated with bloodstream infections in the non-COVID patients. So these impacts are real. We need to think them through, and diagnostics can help us with that. And just going back to seasonal infections, they're seasonal, they happen every year. Why do our hospitals crumble? For me, it's like railway services where they moan about a leaf on the track or a little bit of snow, like it's a surprise. These are seasonal infections, they happen all the time. But we are not capturing the impact they have on the delivery of healthcare. Furthermore, we are not capturing the morbidity and mortality associated with their acquisition in healthcare. This is a lovely study from colleagues in Switzerland that looked at the impact of seasonal flu in terms of mortality. The same as COVID. We're not dealing with seasonal infection adequately. So I think the intelligent use of diagnostics can really help us with dealing with emerging infections, pandemic, and the boring old seasonal stuff that we should be dealing with intelligently already. We have the means to do it. And the opportunities to look at this from a whole systems perspective are enormous. So, rapid diagnostic tests, you're going to hear a lot more about these from learned colleagues who'll be speaking. And There's some interesting results, but actually some of them are quite modest, and some of them have kind of unintended consequences of perhaps increasing antibiotic use, or, pretty modest in terms of impact on bed use. However, we're not looking at them at a health systems level, and looking at them in a standalone way is not assessing their impact adequately, and we have to understand the potential interactions across all of healthcare and think about it at a systems level to absolutely understand their value and also how to target them. Decentralized testing is a fantastic opportunity for us. It can be done within secondary care, scaling up point-of-care testing, thinking about bedside or hot labs across networks of hospitals, but also setting them up outside the hospital systems and having hubs. This is an example of acute respiratory infection. Hubs, mobile units where they can do rapid testing, which has significant impact in terms of the burden of infections turning up in emergency departments. We also need to think about home and self-testing. Major advances being made here that we need to be able to harness, link it with data, and the opportunities to collect data at the point of testing to inform EPI. Major advances in lateral flow, microneedles, whole microtesting blood, lots going on that we need to bring together and think about how we can use this across the whole patient journey, inform public health, inform diagnostics, inform preventative measures. This importance of data integration was really demonstrated for us in work that was done within our hospitals during COVID, linking patient movement data to COVID diagnostics with neural networks, and we were able to predict where hospital COVID infections would most likely happen. This is a beautiful bit of work showing the strength of integrating multiple layers of data to inform diagnostics. Then there's also work about how you can use dynamic diagnostics, this is work from Damien Ming, to kind of inform the optimal time to do your blood culture or other tests. So you can use the dynamic changes in data to inform how to use diagnostics, as well as dynamic data as a diagnostic. So the connectivity of the diagnostics is critical. So we don't want just point-of-care tests, we also need to collect data at the point of testing so that that can be integrated into more opportunities for more complex diagnostics, and also things at the and also thinking about the levels of the public health and enabling targeted responses. And the rapid expansion of rapid molecular and metagenomic approaches can really help us with this, but only if we can harness data linkage and connectivity. The other thing is, I mentioned real-world research, doing it in our real-world environments. Whole systems approach will help us enormously. It will enable modeling, recognition of key areas where we can actually target diagnostics, target infection prevention, target vaccines, target specific follow-up, embedding in real clinical pathways to inform our decision makers and us. And remember the importance of the generating of the data to inform further therapeutic decision making and also further AI models. Now, I mentioned before the implementation of diagnostics and that we haven't got it right in terms of the economic modeling of them. Much more work is going to be done on this, particularly from thinking about it from a low and middle income perspective. But it is really inadequate so far, the kind of value-based costing, the value base of diagnostics and understanding their real impact. We need to think about the individual, the healthcare system, and the societal benefits, but we need to do that in a way that enables comparisons, and much more work is going to be done around this. So there are dangers about diagnostics and around artificial intelligence. We have to recognize issues about social determinants of health, reach, and representation, really important. And to remember, the more and more data that we generate that then feeds into models, the more and more we're going to amplify the biases we already have. So it's absolutely critical that we think through this in terms of the representation of diagnostics and the data that they generate. One area that's poorly represented, maternal and neonatal data and diagnostics. I just want to flag that this is an area that we need to do a little bit better on, and I hope that there's some work that's going to be advancing this. So towards the future of diagnostics, we need to think of them in a completely different way. It's not yes, no, treat, yes, no. They are going to be the bedrock of how we deliver care, prevent infection, and manage healthcare safely and intelligently. And we need to think about that and have that type of vision for them. We need to think about decentralization with direct linkage, and then the multimodal aspect of integrating a variety of data together that will support diagnostics. We need to move further. I said societal, but actually we need to think about how the diagnostics and the data that they generate can inform national and global surveillance and policy. We need to have them rapid and responsive, transforming our kind of system of information into a non-linear integrated model. But we also need the frameworks, the legislative frameworks, to enable rapid innovation and adoption of diagnostics, to support innovation, to support implementation. And we are not there yet in terms of the regulatory frameworks globally, and that also needs to be advanced. So we need to broaden our understanding. It's not just static, it's dynamic. We need to extend beyond the individual pathogen, the individual host, the host factors, think about how we can integrate point-of-care therapeutic drug monitoring and dynamic routine data that can be used as a diagnostic. It can steer surveillance, vaccination programs, inform prescribing, particularly in underrepresented groups, infection prevention and control, and prevent the amplification of infection and AMR use within our healthcare systems. But it is a public health tool. They are a public health tool. And we need to think how they can be contextually appropriate in the different environments and the different priorities that different populations have. So, in summary, I think we should think about diagnostics in a whole new way. We need to really convey and make our policymakers and political leaders understand the importance of them. We need to harness the significant technological and data-driven innovations and harness them, and the really critical patient and public input into the co-design of these. And diagnostics should no longer mean discrete standalone tests for individual management, yes, no, but benefit whole systems. And I think a systems approach for the development and implementation will be crucial to combat future challenges in infectious diseases, but also in our healthcare delivery. Thank you.
Thank you, Professor Holmes, for that very comprehensive summary of how diagnostics can impact healthcare and reduce antimicrobial resistance, and that forward-thinking approach. One thing I forgot to mention is that we will be taking question and answer at the end of each session. So if any of you in the audience have questions, please come up to the microphone.
Ephraim Salak from Danaher. So thank you. That was a great vision of where it is that we need to get to, but obviously how we get from where we are today to how we achieve that is going to be a very long road. What do you anticipate are some of the major barriers that we're going to need to overcome in order to realize that future state?
So I think two of the things I said are absolutely critical that we need to get: economic and value-based models of diagnostics, and from a variety of perspectives, but including lower middle income perspective. So economic and value-based analysis of diagnostics. So that's one, so we can make an economic argument. But the other is the regulatory side of things, Ephraim, which is really boring, but critical. You know, when colleagues have rapidly come up with some incredible tests, piloted and everything, but actually they will not be able to be used because even although there's a call for responsive diagnostics, the regulatory frameworks are just not there, and the learning from COVID is not being sustained. So those are the two kind of meaty, practical side of things. But then there's also the kind of mindset of colleagues, and I think citizen engagement is absolutely critical, because we need to move to people will be doing their own type of tests and a variety of different things. People will want to know what they've got when they've come out of hospital. People, I think there will be a demand from the public for more. And I think we should really capitalize on that and use their voice to encourage the adoption.
Thank you.
But in a way that the data can also meaningfully be used for public health as well.
Thank you.
Question? I have a question for you, Professor Holmes. So we know that with the Fleming initiative, there's also the component of communication. So what do you think are the important messages that will resonate with the general public in terms of increasing awareness on AMR?
So in AMR rather than diagnostics, so in AMR more generally, well, I think that's the most central part of the puzzle. And I think we absolutely need civil society to completely understand the challenges, because relying on political leaders is not enough. So we need to sustain the interest and the understanding of civil society to pressurize the addressing of AMR. Just like I said, they would be really useful in pressurizing the role of diagnostics. And one of the things being addressed in terms of communication and addressing one of the action points that came out of UNGA in November 24 was the September 24 was the embedding AMR awareness in school curricula globally. And that's an activity that is taking place right now with the support of WHO, but in a way, thinking about the next generation and making sure that every child around the world, wherever they go to school, there'll be something about it, so that the future may be a little bit safer. And, it's going to be, if we don't die of climate change, we won't have healthcare. Anyway, so the communication bit is beyond just the public, but it's also embedding in education in schools, which we've seen as a really important piece.
Thank you. Thank you very much. So we invite our next speaker to the podium, Mr. Nick Machin, and he will be speaking to us about rapid respiratory testing and his experiences in a Manchester hospital.
Great. So thank you. And yeah, as a virology consultant working in a big NHS trust, I've certainly got a lot of experience about rapid respiratory virus testing, and it'll be a pleasure to talk to you about it over the next 20 minutes or so. Just that's my disclosures. So just an outline then, it's going to be a bit of a story in 3 parts. First of all, I'll give you some background to where I work, which will sort of explain why we have to think about rapid respiratory virus testing. Then I'll talk to you about a couple of experiences that I've had over the last 4 or 5 years. One is doing a pilot of point of care in one of our hospitals, and then more recently, setting up a full point of care service in another one of our hospitals. And then being invited here right now is a really good opportunity. It's very timely. As I'll explain, in our trust, we currently have essentially 3 different workflows for rapid respiratory virus testing. So now I thought it was a really good opportunity for this conference to do a bit of an evaluation of those services and look at some data on quality, and also some data looking more at the clinical utility of these services. So, yes, I work in the laboratory called Manchester Medical Microbiology Partnership, which is based just outside the city of Manchester. There's something slightly odd about this photograph. That's the fact that it is sunny and a clear sky. For those of you who've had the pleasure to visit us, it's normally cloudy and raining. We're called a partnership because we're a partnership between UK Health Security Agency, which is the UK's public health agency, and Manchester University NHS Foundation Trust. And like a lot of laboratories in England now, we're very centralised, so our labs are based in this building complex on the main campus. It's a big lab. We do about 2.8 million tests per year and have over 370 staff. But as I said, our trust is very large, and we have hospitals on 3 main sites, sort of in a line through the city. So in the north, we have North Manchester General Hospital, which is a large adult hospital with an infectious diseases unit and over 700 beds. At the central campus, where the lab is based, we have several hospitals, including Manchester Royal Infirmary, which is a really big adult hospital with 1,700 beds, and a regional children's hospital. And then in the south of the city, we have Wythenshawe Hospital, another big adult hospital with over 900 beds. So just before I go on to talk about a couple of experiences, I thought it'd be good to reflect on why we go to the effort of reducing the time to getting a result for respiratory viruses. And as a virology consultant, there's several reasons, and there is increasing evidence in the literature that show there are benefits. Not all of it is specific to respiratory viruses, but a lot of it is. So there's now quite a few studies, including this one by Nelson et al., that showed that getting a quicker result can be cost effective. It can pay for itself by reducing unnecessary investigations once you've got the diagnosis and potentially reducing hospital admissions. Getting a quick result can have a benefit on antiviral treatment. So there are studies that show that this can significantly reduce the time to the prescription of antivirals for flu. And there are studies, including the big meta-analysis by Mathuri et al., that showed that for patients who are critically ill with flu, getting a quick result and decreasing the time to treatment can have an effect on mortality. Getting a quick result can have a positive benefit on infection control. So there's lots of studies that show that getting that quick result can lead to the patient being isolated more quickly, and there's studies around SARS, flu and RSV. And finally, that quick result can have an effect on antibiotic prescribing. So there are studies that show that point-of-care testing can reduce antibiotic prescribing by identifying a virus. Having said that, though, for full disclosure, when I was sort of doing a review for this talk, there are some studies that show there isn't a benefit at the moment. So I think the jury is still out on that one a little bit. So moving on to the first experience then, if you cast your mind back to the pandemic, I know a lot of you may not want to, but it was sort of middle of 2021. And I think in a lot of healthcare systems, we were having to provide SARS-CoV-2 testing, COVID testing for all our patients that were being admitted to hospital. And at that point, we were providing rapid testing at our central lab using the Cepheid Infinity system. But despite setting up lots of transport between Wythenshawe Hospital in the south and the main lab, we were still struggling to get good turnaround times. So we thought we'd try setting up point of care in our emergency department at Wythenshawe. So space was in short supply, so we had to place the instrument, which was a Cepheid Gene Expert 4 module in the sluice. For those of you who don't know what a sluice is, that's where all the bodily fluids and waste get taken. I can promise you that it stopped being a sluice for the pilot and was thoroughly cleaned. And this is a picture of Adam, one of our trainee clinical scientists who kindly volunteered to stay in the sluice to do the testing. At the time, the instrument had a laptop, so it didn't meet our trust strict requirements for point of care, so it had to be operated by a laboratory-trained member of staff. And the way the pilot worked was in the first week, patients being admitted to the ED had a point of care test using the instrument. And then in the second week, we had a comparator week where patients got a standard of care test and the sample was sent back to the main laboratory. And at the end, we compared the turnaround times between the two and length of stay in ED. So the first chart shows, as you'd expect, a significant reduction in turnaround times for patients that had a point of care test. And the majority of that was due to a reduction in transport time. I think more interestingly, though, you can see on this chart that when we looked at the length of stay in the emergency department, patients that had a point of care test in that first week had a significantly shorter length of stay. So bear in mind these weeks were run consecutively, so there may be other factors that affected this, but it's interesting to think that getting that quicker result may have led to quicker decisions about where to move the patient, therefore improving patient flow. So fast forward to middle of 2023, and Cepheid released their Gene Expert 4 with a touchscreen, and this met our trust's strict requirements for point of care because it had a more easy-to-use interface and the screen could be wiped clean, and it also had good IT connectivity, which I'll talk about in a minute. And at that point, North Manchester General didn't have any rapid testing on site, so we thought we would set up a point of care service in the emergency department there. So this time we had a dedicated room, not a sluice. We placed the 2 instruments in this room. You can see lots of signage giving instructions on how to use the instrument. Got racks for storing samples, and you'll see cleaning fluid bottles for regular decontamination. And we ran the Expert Express SARS-CoV-2 flu and RSV assay, and that's the same one that we use at our central site. So staff training is really important when you're setting up point of care, and we did a lot of work training staff. We trained 2 groups of staff. The main one was clinical staff in the emergency department, and we chose to use healthcare assistants who work with the medics and the nurses to do tasks like basic patient care, observations and testing. We also, though, trained up another group of staff. As it's probably a bit unclear, but if you can see from the site map, the emergency department is based at the end of a long corridor, and we wanted to make the testing available to other clinical areas. So we trained up the bed managers, who are a group of staff that it's their job to make sure patient movements around the hospital run smoothly. And they're on site 24 hours a day, 7 days a week. So they're a good group of staff that has access to all the clinical areas. So the way it works is they will bleep the bed manager will collect the sample, take it to the instrument and do the testing. Just want to go into a bit more detail with the workflow, because as I said, IT connectivity is really important. It's a requirement in our trust to make sure the results are available to everybody at all times, that they're traceable and auditable, and it reduces transcription errors. So the clinician requests a test on our electronic patient record system called Hive, and at the same time the sample is taken, combined nose and throat swab placed into viral transport medium. That test request then goes into a piece of software that we call the middleware, and that's exists in our hospital for all point of care devices to connect them to the electronic patient record. The sample's taken to the testing room and an aliquot is taken out using a pastette and placed into the test cartridge. That then goes to the instrument and the patient's hospital number is put into the instrument and the test is done. And then that goes back into the middleware, and only if that patient ID matches with the request is the result then sent back into our electronic patient record, and then it's available across all our sites. It's also actually available to patients via the MyMFT app that they can download onto their smartphones and view their results. So sorry, this is really hard to read, but it's an example of one of our results. It's positive for flu A, and there's just a couple of points I want to pick out from it. One is that we do make the CT value available. It's at the bottom, it's really messy. We need to clean that up, I think, do some work with it, but you do get the CT value because it's a PCR test, and that can be important for clinical decision making. Because this is positive for flu A, we also have a comment saying that if the patient is critically ill or immunocompromised, we ask for a follow-up sample for lab-based subtyping. That's important for 2 reasons. One, clinically, it can be important if they're critically ill. It might affect the neuraminidase inhibitor that you prescribe, but also with my public health hat on, we don't want to miss any introductions of avian influenza into the human population. As I'm sure a lot of you will know, there is a pandemic of H5 avian flu at the moment. And worryingly, we are seeing introductions of that into other animals, in cattle in the US. We had a sheep in the UK 2 weeks ago. So the unavailability of point-of-care testing for subtyping is a bit of a concern. And if anyone has got any experience of getting that point-of-care sample back to the lab, I'd be really interested to talk to you about it. So moving on to the evaluation then, as I said at the beginning, not particularly by any design, but at the moment we have essentially 3 different workflows for rapid respiratory virus testing in our trust. At North Manchester, we have the point-of-care service. At the central site, we do lab-based rapid testing using the Infinity system. And at the south, we didn't set up point-of-care in the end because of space. We have a hot lab with an instrument in our biochemistry department. So I thought it'd be good to see how those 3 workflows stack up in terms of some quality metrics and some clinical utility data. So this chart, on the left-hand side, you can see the positivity and negativity rate, and that's all test positivity and negativity. And on the right-hand side, you can see bars showing the error rates, invalid rates, and no result rates for the 3 work streams. So I'm reassured to see that the positivity rate, there's no significant difference between the 3 workflows. The reason why I'm pleased with that is that we do worry about contamination with point of care, and it's reassuring to see we're not seeing a higher level of positives, which could be false positives. The error rates are a little bit higher for the point of care work stream, but they are within acceptable limits for our trust. It's interesting that when you dig down, the most common error was sample volume. So I think what's happening there is when they're taking the sample, they're not adding enough to the cartridge. But it's a relatively new work stream, and I think that's just a training and education issue that we need to work through. So moving on to some data looking at the clinical utility then, I just chose to look at patients who were admitted through one of our 3 emergency departments and had a test using the 3 pathways. Last flu season, and this data goes back, I think, to about November last year and runs through to the end of February. And it was a busy flu season. We did a lot of testing. We were doing at the peak around 450 tests a week at our main site, and then around 200 tests per week at the peak at North Manchester and Wythenshawe. You'll see from the graph that we were still sending a few samples from North Manchester and Wythenshawe to the main lab for testing. And again, that's something that you have to sort of grapple with when you're setting up point of care services. We still wanted to make sure that there was availability for the clinicians to request a centralised test in case the instruments ran out of capacity. And I think, as we all know, predicting respiratory virus epidemiology is very difficult. So managing that capacity, but making sure you've not got too many instruments can be difficult. This graph essentially shows the turnaround time for the 3 work streams, and as you'd expect, the point of care is significantly shorter. Interestingly, though, this chart shows the time from when the patient arrived in the emergency department to getting their result. And I'm a little bit disappointed with this because, as you can see, the patient's getting a point of care test. The result wasn't necessarily arriving any earlier in that patient journey. So I think there may be some education there working with clinicians to make sure that they're using the services that we provide to the best of its ability. Interestingly, though, this final chart just shows the time from when the swab was taken to when a neuraminidase inhibitor was prescribed for patients that were influenza A positive. And you can see that it was significantly shorter for patients that received a point of care test as compared to patients in the other 2 workflows. So I'm not quite sure why that is, given that the result wasn't arriving any sooner in their pathway. And again, we have to bear in mind this wasn't a controlled study. There may have been other factors in the patient journey that affected this. But it's interesting to think there's something about getting that result close to when the sample was taken that is prompting clinicians to prescribe. And as I said earlier, there is some evidence that doing that for flu can have benefits, especially if patients are critically ill. So just to summarise then, I think it's definitely fair to say that rapid respiratory testing can be an effective tool for managing respiratory viral infections. And as I hope I've maybe got across to you a little bit, providing rapid testing in a large trust is complex and challenging. Our job as microbiologists and virologists is to work with the various options that are available to us, balancing the pros and cons and the cost. I think at the moment we are achieving good turnaround times across all our 3 workflows, but there is potential there to develop those services further. I think we've shown that point of care does provide even more rapid results and in our hands is reliable and accurate compared to lab-based services. And there may be the signal that it does have this benefit in terms of decreasing the time to prescribing. So my job now is to sort of dig into that data more, do some more analysis. And I think if we can show that further reducing that time does have a benefit for patients, then it's something we will be thinking about rolling out further. So I won't go through all my acknowledgements, but just to thank the point of care team at North Manchester General and also Dr. Ahmad, who is one of my colleagues who worked on the data for me. So thank you very much.
Thank you very much for this presentation. If there is any question from the floor. Not yet. I have one question for you regarding do you have any regulatory issues to put an automat in the clinical settings? For example, for us in France, this automat should be managed by a biologist. So the biologist should come from the laboratory to manage the automat each days, weeks, but there is some regulatory issues. Do you have something like that?
Yeah, I'm not entirely familiar with the legal regulatory status in the UK, but certainly within our trust, we have very strict requirements and it is managed by, not by microbiologists, but our point of care service is managed by biochemists. So they are part of the pathology department and there are teams on each site whose job it is to manage all of the instruments that we have in our trust and to make sure they comply with quality assurance, quality control.
I was curious in the long time to result from when patients first arrive to when the test is available. I think it was 5 hours or so in the ED setting. I guess who's placing the orders? Is it does the patient wait until they've seen the physician? Is there an opportunity, for example, at the time of triage, if they present with a respiratory syndrome, for the nurses to collect the sample and potentially get that result even earlier? And then second question is, from your experience, do you see opportunities for other point of care testing that you can implement at that site of care above and beyond just the respiratory fourplex, for example, in order to really help move patients through and get them the diagnostic information sooner?
Yeah, thank you. It's a really good question. And I think it's something I need to dig into a little bit deeper. But what I suspect in the NHS, obviously cost, well, in all hospital systems, cost is important. And I think what we don't test patients if they are not going to be admitted to hospital in order to limit the testing numbers. So therefore, they end up getting tested later in their ED pathway when they've been seen by a clinician and that decision to admit has been made. So I think having done this analysis, I'm going to go back and see if we can do something about that to make sure the test has been done earlier in the pathway. I think to answer your second question, yeah, there's a lot of things that I'd like to do at point of care, but it's making sure that it matches with our strict requirements, IT connectivity and user interface. Certainly for our more critically ill patients, there are extended respiratory panels that it would be good to do. But again, the jury is out a little bit at the moment as to the clinical benefit of those. CSF testing, I think, would be really good to rule in viral meningitis. But again, I'm not entirely sure there are any instruments at the moment that would necessarily meet our point of care requirements.
If I could follow up on the timing, it was interesting that it's only for the patients getting admitted that you're doing the testing, and I'm wondering whether from a workflow improvement, right? If perhaps for a less ill patient, if you get that diagnostic information earlier and get the patient out of the emergency room in 1 to 2 hours, does that provide an opportunity for cost savings just in terms of resource utilization? And is that a consideration in terms of where the investments are made in terms of the testing?
Potentially, yes. And I think there have been studies that have shown that. So, yeah, my job is to go back to my hospital, do a business case and see if I can convince my bosses. Yeah.
Well, thank you.
We have a question from the application. So did you note any increase in the number of tests since they are directly available as POC in the world?
I have to be careful because I haven't done that analysis formally. I think, yes, it has. And I think we do see that when it's more readily available, it will go up, but I'm not 100% sure.
Thank you, Mr. Machin. Thank you.
Thank you.
And I invite our next speaker to the podium, Dr. Jennifer Havens. And Dr. Havens will be speaking to us about her experiences in Kentucky in the Key Treat trial and using a model of care for HCV testing in rural Appalachia.
Thank you so much. I'm going to be talking to you today again about the Key Treat study, but specifically about how point-of-care RNA testing has changed our approach to hepatitis C treatment in very rural areas of Kentucky. So just to acclimate you to Appalachian, Kentucky, so all of the counties that you see outlined are part of Appalachian, the Appalachian Mountains of the United States, the eastern part of the U.S., and you'll see the circle, which encompasses the county that we are in, Perry County, Kentucky. And you'll also see a lot of these counties are shaded in red, and these are amongst the most economically distressed counties in the United States. So in 2015, there was an HIV outbreak in a very rural area of Indiana that was primarily caused by the sharing of injection paraphernalia used to inject prescription opioids, which was different than a lot of the HIV outbreaks we've had related to injection drug use. So as a result of this outbreak, a hotspot analysis was conducted by the Centers for Disease Control and Prevention, and 25% of the counties that were identified as hotspots were in Appalachian, Kentucky. So this is certainly the epicenter of the opioid epidemic in the United States. And as we all know, where there is increase in injection drug use, we see hepatitis C often will follow. So the impetus for the Key Treat study, we've been conducting a longitudinal cohort study in Appalachian, Kentucky, studying the opioid epidemic since 2008. We recognized very early on that there was a phenomenon happening in this part of the country, and oftentimes our drug use trends don't start in the very rural parts of the US. So this was really different, and for me, very interesting. And again, where we have injection, we have an infectious disease. So we were interested in looking at HCV and HIV in the context of the opioid epidemic. We found that the vast majority of folks that we did antibody testing on, point-of-care antibody testing, were indeed antibody positive. And we did do a one-time blood draw to determine treatment eligibility, so RNA, and found that about half of the folks enrolled in our cohort were treatment eligible. But at the time, if you're aware of the health systems, 50-plus health systems in the US, you know that the Medicaid restrictions made it very difficult to treat hepatitis C in the US up until very recently. In some states, it's still very difficult, especially amongst people who use drugs or people who inject drugs. A lot of the restrictions were really designed to keep treatment out of the hands of people who are using drugs. So the goal of Key Treat was to conduct a microelimination study in one of these counties that was severely impacted by the opioid epidemic, and now what we're calling the opioid HCV syndemic. So if you're interested in our treatment protocol, it was published a couple years ago. But briefly, our eligibility criteria had to be at least 18 years of age and a resident of the county, since this was a microelimination study. And once we established over this phone screen that they were eligible, they came in to do the in-person screening, where we verified their age and residency. And the main eligibility criteria, obviously, for the study was that they were HCV RNA positive, not pregnant at the time. In 2019, there was still a lot of hesitancy to treat pregnant people with DAAs, and they had to be able and willing to consent. So we screened, this is a town of 5,000 people and 28,000 people in the county, and we screened over 1,000 people, if that, just to give you a sense of the acute nature of drug use in this part of the country. And of the 990 who were eligible, 762 showed for in-person screening. Even though we called and called and called, we still lost people. And if you've ever seen a diagram of the HCV care cascade, there's this huge drop-off from antibody testing and to RNA testing, and then RNA testing to treatment initiation. And what we were trying to do was really to kind of clear up that cascade and have it be a one-step process. So at the end of the day, 380 folks were eligible. Those who weren't eligible were either antibody negative, RNA negative, or pregnant. So again, phone screen to determine eligibility, then finger stick draw. That is a huge game changer in terms of diagnostics. So in these very rural areas of the United States, finding someone who can do phlebotomy, who is trained in phlebotomy, is extraordinarily difficult. And if we're going to be thinking about diagnostics, taking it out of the healthcare setting and into the community, we need tests where phlebotomy is not required. So a finger stick test, like the one that we utilized, is vitally important. So from that finger stick draw, we drew 500 microliters, which sounds like a lot of blood for a finger stick, but once you've done it a few times, it becomes fairly easy to do. So there's a little bit of training, there's a little bit of a learning curve, but once you get there, it can be very easy to do. And again, it removes the necessity for the phlebotomist. So anyone who was antibody positive, we went ahead and use the HCV. We were using, at the time, the research use only European version of the test. We were the only folks, I believe, in the US who were using the test. We received an exemption from Cepheid to use this with the promise that we would do confirmatory testing, which we did, but we were able to initiate folks same day if they were RNA positive with the point of care test. And those folks who are RNA positive were initiated on soft-fel, same day. So this is a same-day test and treat model. Folks who were either antibody or RNA negative were invited to rescreen, and we did have 7 people who ultimately came back at some point and were included in this study. So one of the big questions we get is, do you do sequential antibody and then RNA testing? Do you wait for those test results to come back? In different parts of the world, you have the availability of the really rapid HCV tests, so the the biolytical, which is 1 minute, versus we use OraQuick, which is more like 20 minutes, but truthfully, if they're RNA positive, the OraQuick usually comes up with it in about 5 minutes. So if you have what you think is a low prevalence population, it's probably worthwhile and more economically advantageous to do the antibody and then the RNA testing for antibody positive folks. But if you have a high seroprevalence area, moving right to the RNA test may actually make more sense so that you're not utilizing 2 tests. So for our study, folks who were indicated that they had been actively injecting drugs, we skipped over the antibody test and went right to the RNA test. But interestingly, we did an analysis, and in our screener, our phone screener, we said, has anyone ever told you you have HCV? That was 100% predictive of whether they were antibody positive, which is really interesting. So I think that very easy question could end up saving you, in the US, it's about $18 for the point of care antibody test, could actually save you $18 just by asking that simple question. Most folks actually do know. So our model of care was advanced practice provider. So in our case, we had 2 nurse practitioners. Streamlined enrollment, like I said, same day test and treat for the vast majority of folks. We did regular point of care testing every time they came to us. We did point of care testing, and that allowed us to understand at what point during treatment folks were undetectable, which was actually really interesting, and I'll show some of those data. We did some extended follow-up. What we don't have in the literature is long-term follow-up, especially among people who use drugs, in terms of reinfections. So we were doing 6 and 12 months post-SVR to learn about reinfection. We also did Hep A and Hep B vaccinations. We did a full lab workup for HAV and HBV, and if it was determined they were not immune, we offered vaccination for folks. And interestingly, our uptake rate was actually really high, which is surprising for the US, in this part of the US in particular. So we had a whole lot of visits. So I will say this is same day test and treat, but this is not low threshold, low barrier. That's something that we learned over time. And probably moving forward, we're always going to think about low barrier, low threshold. And I'll show some results, which is really kind of informing that decision for us. But again, we did the finger stick screening. We had to do enrollment labs at the time because we needed to learn about their HBV status. In particular, if you're aware, DAAs do have black box warning about the potential for HBV reactivation, so we do need to know their HBV status. And we did some other testing as well. And we chose Cepheid because it has a great side effect profile, 1 pill per day. When we actually asked them before the study was started, would you rather have 1 pill per day or 3 pills per day, even though there were a different amount of time, they preferred 1 pill per day. So 3 things I'd really like to point out. So number 1, transportation. So this is a very rural part of the US. There is no public transportation, so no buses, no trams, no subway. There are no taxis. There's no ride share services. So people are entirely reliant on either having an automobile for use or having a friend or family member to drive them. That ended up being an enormous barrier to care. About a third of our folks were actively injecting, mostly methamphetamine. If you can get someone who's injecting methamphetamine several times per day through treatment, you can get anybody through treatment. And a lot of folks were actually enrolled. This was not part of the study, but a lot of folks were actually already enrolled in medications for opioid use disorder, so buprenorphine and or methadone. So I said same day test and treat, but we were cautious because again, this was 2019. This was before all of our new recommendations that say, guns blazing, get everybody on treatment day 1. We would have loved to do that, but we were a little bit more cautious here. There are some drug-drug interactions for Cepheid, and so we did keep those in mind and asked them to, if at all possible, change those potential drug-drug interactions. And then we asked folks about HBV. Well, they knew about their HCV status. They didn't know so much about their HBV status. The vast majority of folks who said, yes, I've been told by a clinician that I am HBV positive. At the end of the day, it was actually very low. And we didn't have to initiate, upon further testing, we didn't actually have to initiate anyone on HBV treatment in addition to their HCV treatment. But we were able to get almost 97% of folks, once we resolved these potential issues, on treatment. Any clinical trial ever done over time, you have loss to follow-up. It's just, and we're working with a population where loss to follow-up is actually an even larger problem. But interestingly, since we were doing point-of-care RNA testing at every visit, we learned that about 40% of the folks that were lost to follow-up were already undetected by the time we lost them to follow-up. So obviously from a clinical trials perspective, that isn't great. We don't have SVR data on them. We don't have their outcome data. But from a public health perspective, that's huge, right? Because we know that they are likely, especially if they're injecting drugs, no longer transmitting the virus, which is huge. So again, undetectable RNA, we were able to look at that because we did have the data from the point-of-care RNA test at every single visit. And by 6 weeks, so halfway through, and this is not with great adherence. The one nice thing about DAAs, they're incredibly forgiving. Even with not spectacular adherence, we were seeing 80% undetected by 6 weeks. In terms of our SVR rates, so those intent to treat includes those folks, unfortunately, who are lost to follow-up, but our per protocol, so amongst those who did complete treatment, we're up around almost 95%. And that is comparable to a lot of the studies that have been done in similar populations, mostly in urban areas. To our knowledge, this is the first study that's been done in a primarily rural area. Reinfection is really low. That's one of the things we hear time and time again amongst people who are treating hepatitis C, and their resistance to treating folks who inject drugs is that, well, they're just going to get reinfected. Well, we had folks who were, again, actively injecting multiple times per day, and our reinfection rates are actually a lot lower than some of our comparable studies. So we were successful in recruiting, treating, and curing rural individuals infected with HCV, including people who use and inject drugs regularly. But I think I can't emphasize this enough that the reason that we didn't have 50% loss to follow-up or that huge drop-off in that cascade of care is because we were able to employ point-of-care RNA testing, and specifically the finger-stick point-of-care RNA testing. It was huge in allowing us to initiate the vast majority of folks the same day and not have that loss to follow-up that we would have if we required multiple blood draws, multiple visits for them to actually even just start the medication. And we saw very quickly, so by 6 weeks, the vast majority of folks were already undetectable. If we're thinking about treatment as prevention with people who inject drugs, the sooner we can get them initiated on DAAs, the sooner that we can get them undetectable, and they're no longer transmitting the virus, which is huge. And that's the only way we're going to be able to achieve elimination. So again, I talked about transportation, and anything we do moving forward is going to have to be low threshold, low barrier. So same-day test and treat, yes, but also give them the entirety of their course and send them on their way, see them once to diagnose HCV, see them once to cure, to determine whether they've been cured. That's really all we need. We can do that all using point-of-care RNA testing, finger stick only. The point-of-care diagnostics that are necessary to treat HCV, so including HBV, that's coming down the pike. There are finger stick tests for FIB4, so to determine fibrosis. So all the things we need to have a comprehensive HCV treatment program, we can now do with finger stick testing, either now or in the very near future. So impact to point of care testing, diagnosis, adherence, cure, reinfection, we were able to look at all of those things using our point of care test, which again, I think we're one of the first studies to be able to do that and to demonstrate the utility of point of care RNA testing for a comprehensive HCV treatment program. And to be able to tell someone, especially someone who's been actively injecting meth, that they've been cured, this is the one good thing that has happened in their life in the past, 4 or 5 years, and to be able to give them that information in person and not just say, hey, we'll call you with your results, is so impactful. And we have data on changes in behaviors post-SVR that we're going to be able to look at, but I can certainly tell you anecdotally, they make a lot of positive changes just from getting cured for HCV. That's that one thing that's kind of the impetus to make other changes in their lives. So being able to give that information to them in person because we had the availability of the point of care test was so impactful for us as researchers. I need to acknowledge NIH for funding this study, and I hope they continue to fund studies like this in the future. And a drug donation from Gilead, because at the time our Medicaid requirements would not have allowed us to do same-day test and treat. And frankly, they still don't in Kentucky. We still have a prior authorization requirement. So I think hopefully these data will demonstrate to our Medicaid, across our Medicaid systems around the country, that same-day test and treat is the way in which we need to move if we're going to actually eradicate HCV in the United States. Thank you.
Thank you, Dr. Havens, for that overview. I open it up to the floor. Any questions?
Yeah, I have a question. Thank you very much for this very, very nice talk and for taking care of this patient in those very difficult situations. I think it's very important to show, especially in this population, how the diagnosis and the treatment can really improve the patient pathway. I have a question. Did you take the opportunity, or will you take the opportunity of having this patient on site to do some other management like HAI or STI? I mean, being able to build this relation between the care and the patient by providing the test and the treatment the same day, is it also a way to improve the relationship between the healthcare system in general and those patients?
Yeah, that's a fantastic question. And moving forward, I think it's going to be really important when we're talking about elimination, about meeting people where they're at, right? So we've gotten the vast majority of the easy people to treat, right? Our baby boomers, when the DAAs came out, we managed to get all of them. The folks that we are going to have to find and treat are those who are not necessarily willing to come to the healthcare system. So one of the things that we thought was really important for this study was to, of course, treat them with the utmost respect, but to gain their trust back of the healthcare system so that they would seek additional services and say, hey, I realize that this is highly stigmatized. I've had a lot of problems in the past when I went to seek healthcare, but hopefully being a part of the Key Treat study renewed their trust in the healthcare system, and they would go out and seek additional services. I would love to have a fully comprehensive program, right? And the next, I think, step for us is, again, taking it out into the community, so out of the healthcare system to our syringe services programs or on a mobile van and going out and meeting people where they're at. And I think that it would certainly benefit us if we didn't just target HCV, but also STIs or any other potential infections that they may have, that we could, if we've got an express system sitting in front of us, we should use it and utilize it to the best of its ability and do as much as we can while they're sitting in front of us.
Thank you. Thank you.
Hi, Anna Niewiadomska, Oxford Nanopore. Really inspiring talk. Thank you for all that information. You also mentioned that there's quite a large population that's HIV infected. Did you?
No, only 2 people.
Oh, okay.
Yes. So it's actually a low seroprevalence area for HIV, but those 2 folks were already under the care of a physician for their HIV, so we didn't have to treat co-infection.
Okay, and then other question, how long was the follow-up for to look for reinfection or
12 months post-SVR. So we're just finishing, we have maybe 5 people left for their 12-month post-SVR to look at reinfection.
Okay, and is that going to be extended if you're refunded?
No, so this study ends in July, unfortunately, so we won't, but we have lots of additional plans for studies.
Okay, thank you.
Thank you.
I have a question for you, Dr. Havens. So presumably, you've given us some information that after treatment, some of the patients experienced an improvement in their quality of life and overall were responsive to the treatment, even though some of them didn't even have to take it, or you saw undetectable viral loads very early on, even earlier than the 12 weeks. Are you also doing a qualitative assessment of their experience at the time that they were tested? So were they open to the finger stick test? Did they have any concerns about it and what they thought about being placed on therapy that same day? Anecdotally, we've heard some concerns in the older HIV literature that maybe people would be resistant to same-day test and treat. What was the patient's experience?
So their response was really positive because, especially amongst folks who had attempted to access treatment before, it was a multi-step process. It was several blood draws. So they would get an antibody test via blood draw. Then if that was positive, they would be invited to come back to the lab to do another blood draw to test for RNA. Then maybe it would be 3, 4, 6 weeks until they could get back in the clinic to actually start to discuss treatment. So the fact that we were able to do same-day test and treat with a finger stick was so advantageous for them. They saw that as a win. It was really minimizing the time, and they thought it was really respectful of us for their time. So they would say to us, it's like you really think about us and the time commitments that we need to make to treatment. And in the past, it just seemed like so overwhelming a commitment. And this is allowing us, when we're motivated and ready to start treatment, it's letting us do that day. So it was huge.
Yeah, thank you. Excellent talk. I guess I'm going to ask you to speculate on something that's probably unfair. So, I totally agree, right? When you're talking about these populations, these are people that have not had a lot of positive experience with traditional institutions. They go to a public library, they get kicked out. They've never had a good experience with a police officer, a firefighter, et cetera. So we have to go to them, or we have to go to the places that they want to go. Well, the problem is that a lot of these places, these safe injection sites, these, opioid antagonist clinics, pharmacies, are not rich, to speak bluntly. So we're going to need somebody to pick up the bill for the testing for the drugs. So I guess I'm asking you to speculate, what is the evidence needed to provide to a payer, be it a private insurer or, in a lot of countries, the government, to convince them that this is all in worth it to the society? Any thoughts on that? What kind of evidence needs to be generated?
Absolutely. So we are conducting a cost effectiveness analysis. So hopefully we'll have some data from this specific study. So what we are taking from the test and treat studies that have been done, we're going to CMS, so in the United States, CMS, Medicaid, and we're saying, hey, look, if we can do same-day test and treat, we can minimize that potential public health impact. When you go 4, 6, 8 weeks between being diagnosed and receiving treatment, there's such great potential for additional infections, right? And that's something we don't talk about enough, right? That public health impact, the additional infections averted if you're starting someone on day 1, you can project that out. Absolutely. We know that basically for every injector, there's potential for another 20 additional infections, right? So we can model those data and demonstrate the potential savings, the potential infections averted, the potential, obviously, long-term complications of hepatitis C averted. So I think, obviously, a lot of times when we're talking about government and health systems, we need economic data to demonstrate that this is going to be economically viable. Thankfully, at least in the US, a lot of times our CMS particular to hepatitis C is relying on the guidelines set forth by AASLD. They just released new guidelines that are really encouraging point-of-care testing, same-day test and treat, really kind of that simplified model. Because again, the majority of folks you saw in our study, 40 years old, these are not folks that likely have are cirrhotic, that have complications. We can treat them on day 1. So I think if we have some really solid economic data to show that this is a population that should be treated same-day test and treat, and that we should be able to cover those tests. That's our issue right now. Point-of-care testing is not covered by most Medicaid systems. So we need to get the test covered. So we need to get that point-of-care test. It's qualitative now, the FDA-approved test in the US. Some won't take qualitative tests. So, there's barriers, and unfortunately, again, 50 states, 50 different Medicaid restrictions. So it's taking the data as it comes in and demonstrating that same-day test and treat is the way that we're going to hopefully minimize the long-term impacts of hepatitis C on our healthcare system.
Yeah, pay less now or pay more later.
Exactly.
Thank you.
Thank you very much, Dr. Havens. So our next speaker is Dr. Mohammed Al-Zunitan, who is the Deputy Executive Director of Infection Prevention and Control at King Abdulaziz Medical City. And he will be talking to us about antimicrobial resistance and update from the Middle East.
Thank you so much for the introduction, and thank you for the invitations. And today I will be talking about the AMR in one of the hot zones of AMR in the Middle East, especially from the perspective of, we were working in the WHO Collaborating Center for AMR in the National Guard, Ministry of National Guard in the Saudi Arabia, and also the AMR Expert Hub. So this is my disclosure. And in the coming 20 minutes, I will be talking about the AMR, general themes about the AMR, what's going on in the AMR, especially in the Middle East, why it's happening, and what we are doing, and what we're gonna do. And disclaimer, it's gonna be a bit emotional roller coaster. Buckle up. So, antimicrobial resistance is not limited to bacteria. Most of the literature is showing about bacteria, but it's not limited to the bacteria. And absolutely, it's one of the most pressing threats, especially in the 21st century. And if we do nothing, by the 2030, AMR will result in almost $500 billion lost in the health expenses in the next decades, almost $500 billion when we're talking about the productivity annually, and in annual losses about 1 to 3.5 trillions in the GDP, global GDP. And with very simple interventions, like reducing the antimicrobial use in animals by only 30%, that will result, if we use it for 5 years only, that will result in the increase in the annual global GDP by 14 billion by 2050. Just to show you the contrast between what's going on in AMR right now and from this Welcome report in 2020 and how it's going to be in the 2050. As you can see, now we're losing almost 700 100,000 deaths because of AMR. This is projected to be 10 million by 2050, if we compare it to cancer, cholera, diabetes, and others. In this Lancet report, from the 7.7 million annual deaths, 4.9 related to the antimicrobial resistance. And unfortunately, 1.27 million by the bacterial resistance. They are resistant to every available antibiotic for them. And unfortunately, by the 2035, that's expected to double. In the last Lancet review, we are expecting 1.40 million deaths attributed to bacterial AMR. And in 2050, this is going to be 1.9 million deaths related to the AMR. This is globally. And we can avert 92 million deaths between 25 and 2050. Why AMR is happening? And mainly because of the overprescription of antibiotics, not continuing the prescribed antibiotics, using them uncontrolled in the livestock and the fish farming, poor infection control and wash, and lack of antibiotics development. And this is just to show you the cycle, how the antimicrobial resistance reaching a patient, how many ways that they're reaching them, within the hospital or outside the hospital, within the healthcare systems or outside the healthcare system. And this cycle is going. So let me shed some area about the status in the Middle East when it's come to the AMR. So the AMR is still part of the global problem when it's come to the pandemic of COVID-19 that affected the AMR. And it's really exaggerated the problem by the increased antibiotic use, and there is a lot of resistance rates. In the Middle East, in particular, and including in Asia, we have a problem when it comes to gram-negative resistance, and that including the Klebsiella pneumonia and the Escherichia coli. From using the GLASS data that published recently, the leading resistance is happening in the carbapenem resistance Acinetobacter species, followed by the Enterobacterialis resistant to the refrigeration cephalosporin. Ranked fourth is the MRSA, and that followed then by the carbapenem resistance Enterobacterialis. Zooming into individually, as you can see, this is the resistance rate when it's come to the E. coli using the bloodstream infections as a surrogate marker. And you see there is a diversity and there's a change in the epidemiology here. Like the very hot zone when we talk about Iran and Egypt, well, it's not that much when we talk about like Saudi Arabia and Oman and the Gulf countries. Moving to the Klebsiella, the problem is even worse when it comes to the third generation cephalosporin. And when we talk about the carbapenem resistance, E. coli, now the picture is a bit changed. And we see the resistance is now going further into some of the areas in the Imperial region. And that's also happening with the Klebsiella pneumonia to a worsen rate. But the Acinetobacter baumannii, as you can see, it's a different game. Now it's really concentrating in different parts of the region. MRSA is following a very different path. If we take them as a temporal trends, and as you can see, in the beginning, after most of the reasons I will be mentioning, there is very high rates, but that really attributed to a very few ASA that's been submitted. And as you can see, we're going through the years, the resistance rates is increasing. And this is for E. coli, almost similar to Klebsiella pneumonia. And the Acinetobacter was high since the beginning, and is continuing to be high. Aureus, we're seeing very different rates, but it is going to be a problem. Highlighting it to a very part of the what not included in the previous study, if we can see what's the situation from Iran point of view, the carbapenem resistance, it is the top problem, followed by the third generation cephalosporin resistance and MRSA in between, and this is going with the previous figures. But unfortunately in Turkey, it's extremely alarming, the resistant rates when it's come to Acinetobacter baumannii. We're talking about 95 to 97 resistant to everything except the colistin. why this happening in the Middle East when it's come to the AMR. Let's start with the healthcare practice. So we have two influencing factors, the intrinsic factors and the intrinsic factors. The intrinsic factors coming from the fear of complications or the overprescription. We'll talk about the uncertainty of what's going on with that patient. Extrinsic factor is about like the weak antimicrobial stewardship that we're having and the health system related issues and outbreaks, ongoing outbreaks, including COVID. Policy and regulations, we have a fragmented and inadequate landscape when it's come to the policies and regulations across the region, and the lack of regional coordination and standardized policies across the region. Adding to the problem, there is an issue in the agricultural use. And absolutely antibiotic being used, despite a lot of policies prohibiting them as a growth promoter, and being linked to emergence of, for example, ESBL and salmonella species that resist them. Conflict and displacement absolutely playing an essential role in increasing the MR, especially in that area. We're talking about destroyed healthcare infrastructures that are leading to overcrowded, damaged infrastructures, medication shortages, insufficient resources, and refugee camps becoming an AMR hot zones and hotspots. What we are doing and what we need to do. So in September 2024, the Kingdom of Saudi Arabia, through the 4th Global High Ministerial Level Conference on the Antimicrobial Resistance, they have the Jeddah commitments. And the theme was, from declaration to implementation. We need to do something right now. And I will be going back to it in a moment. What else going? We have action plans. Many of the regions, they do have the antimicrobial resistance action plan. That including and not limited to Qatar, Saudi Arabia, Yemen. And most of the countries, they publish their action plans, written action plan, in the WHO EMRO website. And this is just, for example, this is just to highlight what's going on when it comes to Qatar National Action Plan. What is the priorities? What is the objectives, including the AMR surveillance, multi-sector governance, and the awareness and research and innovation? This is just to highlight the public health authority in Saudi Arabia and what are their objectives when it's come to AMR action plan. And this is, for example, in Yemen. They even published their action plan. This is from the 4th High Ministerial level meeting that happened in September 24. So what we mean by from declaration to implementation, we need absolutely to accelerate action through the multi-sectoral partnership for the containment of AMR. Single sector that cannot do them alone is not just the healthcare systems, is not us working in the healthcare only responsible about this problem. It's everyone else. Everybody is responsible. And they noted that out of the 178 countries, they already have their multi-sectoral action plan. And the antimicrobial resistance, only 52 have a functioning multi-sector coordinating mechanisms. And the remaining, they don't have, the sector is not communicating and talking to each other. And every single one of them try to combat AMR on their own. And only 68 have them implemented, have the action plan implemented. The others remain like a paper. So the 4th pillars is the strengthening the local, national, regional, international governance. Then the stewardship and surveillance, and the absolute need for capacity development, then the research and development, and manufacturing and access and disposal. These are the key commitments into these pillars, and they including but not limited to strengthening the national AMR coordination mechanisms, the One Health approach, promote best practices in the antimicrobial regulations and the responsible use, and support the periodic global regulatory covering to enhance the oversight. And when it's come to the capacity building, one of the commitments is to establish the AMR One Health Learning Hub in Saudi Arabia before the end of 2025, enhance the AMR awareness, and ensure biannual ministerial conference for progress tracking and accountability. What is the challenges? Why we're having that? And why we're still having it? As you can see, what the data showed is very limited. And because of the limited data, especially from the conflict zones, disparity in surveillance systems. Countries included in the Middle East, they don't have the similar surveillance system. And absolutely the overrepresentation. So what we're seeing is the tip of the iceberg. They are absolutely an overrepresentation when we're talking about hospital-based studies when we compare them to a community, AMR. And there is a big problem when it comes to the public awareness and education, especially when talking about the AMR. We have absolutely opportunities to the AMR control. We need to strengthen the One Health-based policies across the sectors and expand the AMR through regional collaboration and coordination and implement the antimicrobial and the antimicrobial resistance stewardship training programs and have them implemented in the best practices and invest in the novel antibiotic development and rapid diagnostics to control the current pandemic of AMR and enhance the public-private partnership for the AMR response. These are the regional and the global collaborations, including and not limited to the quadripartite collaborations and the international funding mechanisms and all of them. So, to conclude, AMR remains a very critical global health challenge, requiring an immediate action. It's absolutely needed now more than ever to strengthen our policies, to enhance the surveillance systems, and to enhance the education. Investment in research, stewardship and partnership, absolutely essential. And the most important, we need to act right now in the multi-sectoral coordination through a One Health approach. And it is the key for long-term AMR control. Thank you so much.
Thank you very much for this global overview of what has to be done to decrease AMR. So is there any question from the floor? No, I have one question. So you really emphasize that we need to push in all the direction in the same way, but it's always difficult to push by all the different directions. So for you, what would be the most important one? Improve sanitation, improve education of microbiologists, have some microbiology lab in hospital or in community, improve research in antibiotics. What could be the most powerful tool to go quick?
So thank you for the question. The most two powerful tools right now is enhancing the surveillance to see exactly what's going on from AMR point of view and absolutely implement the best practices antimicrobial stewardship programs to control and to contain the AMR problem right now. And following them is the One Health approach, because the health sector is not only responsible about it, it is multi-sectoral. Is to have the One Health approaches implemented and above the ministries, having multi-sectoral approach into it.
I have a question for you, Dr. Al-Zanidan. In many countries that have increased rates of AMR, people who are sick can directly approach a pharmacy and get antibiotics. Is this something that also happens in your region?
So most of the country, they have a very strict policy when it's come to self-prescribing and purchasing it. And it's really ranging between countries. Like, for example, it's implemented in Egypt in 2023, implemented in Saudis in 2021. But despite this, there is always a way that them have the self-prescriptions, because you cannot really, especially when you have a very large country, you cannot really implement them and enforcing them and making sure it's 100%, especially when it's a new rule. So most of the country, they have a rule to control self-prescribing, and it's only per prescription, antibiotics, but the implementation of the rule remains a challenge.
Yeah.
Thank you. Thank you for this very nice overview of the situation in the Middle East. I have a question regarding the surveillance system. You mentioned that you are one of the main drivers of antimicrobial resistance containment might be the improvement of the system of surveillance. My question is there an implementation of a monitoring or automatic reporting system that will be implemented in your country or even at the regional level, and how this could help in managing the IMR situation in your region?
We're talking about the antimicrobial stewardship programs.
About monitoring the surveillance.
Surveillance.
Yes.
So the surveillance is most of the countries reporting and having the report through the GLASS system for the WHO, and unfortunately right now is extremely manual and is not mandatory reporting. As you can see, most of the countries were having a grayed out from the slides that I show you because they did not share data yet. And once we know more, and hopefully the coming publication will show more, especially after COVID, what is the situation. So absolutely enhancing it, automating it in a very good way, it will give you a more granular than in a whole approach when it's come to the issue in the region.
Thank you.
Thank you very much. And now I'll ask our final speaker to come to the podium, and thank you all for sticking with us until the almost very end. We appreciate it. I'm pleased to introduce Dr. Thomas Bollinger, who is the Institute Director and a specialist in microbiology, virology, and infection epidemiology at DGFI here in, well, close to us in Germany. So he will be speaking to us about the impact of carbapenemase PCR in outbreak management and specifically evaluating some cost effectiveness that he's looked at. Thank you.
Thank you. Thank you for letting me present the preliminary data. And I would start with an outbreak which actually was introduced in the beginning from you. So my disclaimer is that Cepheid sponsored this presentation. So this was an outbreak in London, actually, with 5 hospitals, over 10 months, 40 patients. And then it was Klebsiella pneumonia NDM positive, which is the same bacteria we had in an outbreak in our hospital. Estimated cost, you showed that was 1.1 million approximately, and that splits into additional costs and lost revenue or opportunity cost. And there I just want to point out that the red bars are the opportunity cost, and you see that these are the biggest bars in terms of lost elective surgery, staff time, additional length of stay, and ward closures. And the blue bars is just what you actually have to pay in order to screen, contact precaution, and so on. And we took this as a line to do a cost analysis in our outbreak and whether the screening would be cost efficient or not. So besides the cost aspect, there's also other aspects of an outbreak, as you know, reduced activity of the hygiene team and the rest of the hospital. And this is especially true if you have a prolonged outbreak and we have probably spread or possible spread in the media, which would be always very detrimental to any kind of hospital, enforced surveillance and measures of the health authorities, which can be very different. We have a very motivated health authority setting, which is very laborious for us, to be honest. And then siphon decontamination is also a very difficult thing. So for me, we tried really a lot. We are changing siphons. We are flushing them with disinfection solutions. But my impression is that you can never succeed. You know, it's just about suppressing it, and it'll come back as soon as you stop. And we also have prolonged screening for wards which normally do not screen, and that might be a consequence of an outbreak. So screening can come in different flavors. So you can only screen the contact patient of the positive case, and we calculated that and was actually quite cost effective if you do that by PCR compared to culture, and you save around 900 euro, at least in our setting. Then contact patient and complete ward. We screen this when you have 2 or more cases, and we can have at least one case which we cannot connect to the other ones. Then we think that we didn't catch the source in the beginning, and then we are exceeding or extending the screening. Additional admission screening during the outbreak. This is just to prevent that you have an influx of positive patients which you don't detect in an outbreak, which will then be attributed to a nosocomial case and kind of worsen at least the view on the outbreak. Prolonged admission screening, this can be done, and we have done this in a situation where it did heat a bit up in terms of health authorities, even though I think that the outbreak is still very moderate. And then you can decide whether you want to do PCR or culture. And the major advantage of PCR is that it's quick, and culture is kind of long and also, in our hands, less sensitive. So here's our outbreak. We had the first period, and it was 5 patients. 4 were treated in the urology department. So here you see the first patient who was positive. Then we had kind of a gap. We have a second patient over here, and the third case on the urology department was actually the roommate, who turned out to be the roommate of the first one, but was discharged before anybody realized. And then we had another case, and we decided that we have to implement something. And in order to decide what you implement in order to prevent further cases, you have to know that urology patients are frequently readmitted. So you have the chance that they are just coming back and have been colonized in the stay before, and then re-entry with the stay. So we looked at the digital file of the patients, and we flagged all patients which were potential contact patients. And the idea was that they would be preemptive isolation when they come back to our hospital. However, this was not sufficient or / not working. And as you all know, hospitals are very complex systems. There's a lot of people working in there. And to bring everybody to the point to know something and do something is really difficult. And we didn't succeed in that. So this was the consequence when we said, okay, so we have to set up a screening. And also we had like health authorities visits, a couple of them, who was kind of worsening the situation, I would say. So screening, we started after we had the first 5 patients for 6 weeks. And we did it in the following way. We screened elective patients before ward admission. And here was the discussion. We could do this by culture because they could come 3 days before, and then we just do a culture, or by PCR the same day they were admitted or they were coming for the stay. However, logistics with patients really difficult to organize. It's also kind of a rural area where we live. So we decided to do that by PCR, which was more feasible in our settings. Emergency patients were screened in the emergency room, and they were kept over there until the result was present. And when we had the result, they were sent to the ward, and if in a positive case, they were isolated, of course. When they were negative, they were not isolated. And this was done because preemptive isolation and waiting for microbiological culture was not feasible in that setting due to a shortage of beds. And so we decided not to do that and to implement the screening. And well, the screening ended after 6 weeks, and we had no further case, and everybody was happy, and Christmas came. So then we started in the new year, and then 11 weeks after we had stopped the screening, actually, a new episode occurred in the same ward. And this time we had 5 patients in the urology department which were positive. And we actually immediately re-established the screening, and this time for additional 13 months, actually. We re-evaluated that several times, but due to the fact that we were frequently finding carbapenem-S positive bacteria, not necessarily the same as in the outbreak, we decided to continue that. And no further outbreak episode appeared. So coming to the study design and study description, which we have done, it's a retrospective study. It's the aspect of health economic analysis, comparing PCR diagnostic versus cultural diagnostic in terms of carbapenemase positive bacteria. This is a flowchart of our diagnostic workup. You don't have to look at this in detail. It's just, I just have the picture here to show you that in the labs, this is a relatively complicated workflow. And what we did is then we analyzed the cost of each step and determined the cost of the complete process. So first, from the data we collected, I want to give you an overview about the situation. We screened 2,547 patients, from which 24 were positive, and the red 4 positive, this is hygiene samples. I know that a lot of you would probably coming from Southern Europe or India think that these are really low numbers, and we are happy that it's still the case, but we are trying to preserve this situation actually. In terms of diagnostic, we had a 2-hour turnaround time for the PCR on a 24/7 base, and culture was 38 hours. This is just to make you understand why we have different costs in terms of precaution, contact precaution, or closed beds. So if you look in the picture, we see that we have this Klebsiella pneumonia, and this is only from the second episode, the positive cases. The 5 first cases are not included in here. We had NDM positive Citrobacter foindeyi, Vim positive Enterobacter and Pseudomonas, and we had a lot of, relatively a lot of E. coli OXA48 positive. And we also had, of course, multi-drug resistant bacteria, which were carbapenemase negative in all the tests. So looking, I want to draw your attention to the very right column, and what you see over here, we have quite a lot of positive PCR, where we could not find an isolate. Sometimes we could even scratch over the agar with the loop and reproduce the positive PCR, but we could not nail it down to an isolate. So I'm also, as we have quite a lot of experience with this PCR, I'm quite convinced that this is not unspecific results, but I have no data to prove that. So if you come to the cost, to the actual cost, then remember we had admission, we had swab and isolation in the ER, or just waiting if it's an elective patient, and then we had in PCR, by PCR testing, we were at 0.94% positive cases, and in culture, this were 0.63% positive. If you then look at the cost, so PCR per 1,000 patients, this is if you do PCR diagnostic, and in the lower row, it's culture per 1,000 patients. And of course, the diagnostic cost in the PCR are much higher, with approximately 31,000 and approximately 9,700 in the culture part. And I depicted this as bars above, so that you have a dimension for the cost. Then contact prevention was, of course, much cheaper in the PCR group, because you had a shorter turnaround time, and it was higher in the culture group with 23,000 euro. Post-discharge cost, this is mainly disinfection cost, is lower in the culture group, as this was less sensitive. Whether this is a good news, I don't know, but certainly we had less positive cases with that. And in total, you have approximately 39,000 euro per 1,000 patient in the PCR setting, and you would have approximately 34,000 euro in the culture setting. And this was a bit surprising for me, because I would, by gut feeling, I would have said that culture is much cheaper than it is compared to PCR. But if you look at the bars, that's not the case. And now adding the opportunity cost, which is in this case mainly lost revenue, the picture changes. And if you look at the bars over here, these are the bars which were just you saw in the slide before. And now you see that lost revenue is a completely different ballgame in terms of dimension. And we were rather conservative in calculating bed occupancy of 70%. So here in the PCR group, you had costs from the emergency department, which were around 55,000 euro. And looking in the culture part, you had, due to the fact that we only have 2 bedrooms and that we had to close down the second bed, we had 962,000 euro of lost revenue. And if you sum this up, then in the PCR group, you end with approximately 95,000 euro for 1,000 patients and almost $1 million for the culture group. And we were really precise in calculating all the different steps. So this is a cost analysis of screening, but then if you remember that we had 24 cases, 5 of them were in the second episode of the outbreak, and the other one were Vim and or NDM and Citrobacter and Oxa48 and E. coli. So this would be 19 cases, and we had not a single transmission from all of these patients because they were immediately isolated on the ward. So if you predict that you would probably not have that you would have a transmission without screening, then I calculated the cost for a positive case in different departments. And this, of course, depends on length of stay. And if you go in the urology department, you have 4.6 days length of stay. But before this outbreak, we had an outbreak in the spinal cord ward, and that is a completely different setting. So an acute spinal cord injured patient stays with us approximately 120 days. And this is paraplegia. So if it's tetraplegia, it's even longer. And these patients get a lot of treatment in our hospital, but we have a specialized ward or 4 specialized wards for these patients. And so we have a huge therapeutic center for them. And if you look at the cost analysis for a positive case, so here is the carbapenemase positive case, urology, spinal cord department. Then you have the diagnostic cost in order to find the positive or the carbapenemase positive bacteria. This is the same, of course. Then contact prevention is 67 euro in the urology department. And it would be 1,754 already in the spinal cord department. If you look at lost revenue, it's 2,740 in the urology and approximately 69,000 in the spinal cord department. And if you post-discharge is in this case the same, and if you all sum this up, then we come to 3,000 euro in the urology department for a positive case, and 70,000 approximately in the spinal cord department. And I choose these 2 departments because we had outbreaks in them and they had really different lengths of stay. So concluding this, outbreak control is achieved most effectively by molecular screening. I didn't really show that. I mean, I showed that admission screening obviously prevented us from further transmissions, but also in terms of outbreak control, this is not the only outbreak which we manage by PCR, and it's usually you get very quickly a picture, and then you can follow the frappe fort, frappe vite, this hit hard and early, and kind of shut it down. So then cost efficiency of PCR mainly depends on isolation regimens in the screening setting and the availability of single bedrooms, which at least in Germany is usually not the case. Prevalence should be taken into account for the diagnostic process, because the higher the prevalence, obviously, the more effective a PCR screening might be because of not transmitting the bacteria to other patients. And ward length of stay is a major factor in terms of cost calculation. So in the end, I want to thank all the people who worked in the project. So this is the hygiene team in the department. Then we had Sebastian Leierer, who was doing a lot of the statistic analysis from our LRS, the laboratory team providing the 24/7 diagnostic, urology department who helped us enforce the hygiene measurements, ESCMID, which is a company which is supporting us in the cost analysis with Katja Kikul, Michael van der Meijs, and Michael Haylock, and Cepheid for sponsoring our project. Thank you.
Thank you very much for this presentation. Is there any question? Yes, we have one question from the floor.
Hello, thank you very much for this interesting study. It's Rindal, I'm from Lebanon, clinical microbiologist. I wanted to ask you regarding the few cases, not very few compared to the total positive carbapenemesis patients, those that were not detected by culture. There were a few number of them.
Yeah,
did you consider them, did you look into why the culture wasn't positive at the time? Did you consider them as really colonized, and did you isolate them, those patients?
Yeah. Okay. So the first question, it's known for OXA48 that you cannot always catch and isolate. And second question, well, in a urology department with 4.6 days of stay, we rather isolate than taking the chance that they kind of spread this. And it's also a good question, as we know also from VRE, that initial culture screening is not so sensitive. But if I challenge the patients with meropenem or other broad spectrum antimicrobials, I kind of shift the balance in the gut, and then you might have even higher numbers of this carbapenemase positive bacterium. And this, of course, makes it probably more likely to catch it. But in the initial admission screening, we didn't catch it. But like I said, it's nothing really surprising, and which I didn't say. But the other way around, we find not a single case where culture was positive and PCR was negative.
Okay. And throughout the stay of the patients, did you screen again by PCR every week or?
Yeah. So in the outbreak setting, we screened every week. On a special day on Wednesday, we screened everybody, no matter how long the person stayed on the ward. And this was done by culture, actually. And the reason why we did this on a point was it's really difficult to organize that you have to tell the staff, you have to look after 7 days, test them again, and so on. So we just did this also to get a feeling whether the outbreak is not going to continue.
Okay, thank you.
The economics was really compelling, and what I wonder is the direct costs associated with an outbreak are very easy to appreciate, but really the value of screening comes when you look at the opportunity cost. How much success have you had convincing the people at the hospital who control the dollars and the flow of dollars to take that into account, because they're usually just thinking about what they actually have to spend as opposed to what they potentially could lose?
Yeah, I think they still were a little bit in the COVID coma, and so it was easy to convince them. It's getting harder now, but that's why we do the analysis, because I was always convinced that what we are doing is cost effective in the end, but I was never able to calculate that. And as we all were overloaded in COVID and also post-COVID, we didn't have the time to analyze that, and that's now the chance to do that. And I'm quite sure I have a very rational CEO. So if I present the data to him, he'll understand that this is an economic person. Yeah.
I have a question. So I don't know if you have checked the data or not. Did you have at least the feeling that some particular carbapenemase, OXA48 or NDM, could be more valuable to use this type of systematic screening or not, because the dissemination is not dependent on the same manner. For example, for NDM is more clonal dissemination of your Klebsiella, for example. For OXA48 is more plasmid dissemination, so it means you will have some patient with E. coli, some other with Klebsiella, some other with Citrobacter, and Citrobacter will go in the siphon, as you said. So, do you have data or feelings that it could be better for one or the other mechanism?
Unfortunately not. So I do not have the possibility to do the sequencing in my lab. And I requested that from the health authorities, which they provide a lab in Bavaria, where you just send the samples and they do the analysis. But I couldn't convince them for the E. coli, because the E. coli, they were really clustering in 2 or 3 months. And so I sent the data to them and said, well, this might be worth looking at, whether we have an outbreak or a source outside the hospital. But they refused that actually, and I also explained that this might be a plasmid outbreak, but unfortunately I couldn't receive any data for that. Yeah.
Thank you again, Dr. Bollinger.
So thank you everybody to be there with us to the end of this session, the end of this Integrity Symposium.
Yes, and a big thank you to all of our speakers for their excellent presentations and giving us a global view of AMR and other near-patient testing. And so with that, I will close the session. Thank you again to the audience for sticking with us.
Thank you.